Hello everyone, welcome to my channel Prosthodontics. My name is Dr. Ramya Bin. I am a prosthodontist. Through my channel, I will teach you the chapters of the prosthodontics to make you understand better and allow you to love prosthodontics more. Today I am going to start with the most interesting and as well as difficult subject of the prosthodontic to understand, that is removable partial denture. Under removable partial denture I am going to start chapter wise. Today is introduction and classification of removable partial denture. If you understand removable partial denture, then prosthodontics is just a piece of cake for you. Okay, it is really interesting. So let us begin. Before beginning with the chapter, let us first understand what is prosthodontics. Prosthodontic is a branch of dental art and science that deals with replacement of any hard and soft tissue of the oral cavity as well as the face, and it will restore and maintain oral function, form, appearance and health. Next, what is removable partial denture? Removable partial denture that replace some teeth in partially dentulous area, or you can say that it is readily inserted and removed from the mouth by the patient. So it defines the removable partial denture. Next, let us talk about some terms related to the dental prosthesis. That is, prosthesis is an artificial replacement for missing body part. The dental prosthesis is an artificial replacement of one or more teeth and associated structures. In clinical application, dental prosthesis may be supported by teeth, residual ridge, dental implants, or combination of all together. Next term is abutment and retainer. They are a central point of discussion when we discuss about the prosthesis. Abutment could be either tooth or dental implant. It will support the prosthesis. In this picture you can see the tooth is providing support to the retainer. It is not same in the concept of fixed partial denture. Traditionally, fixed partial denture have been attached to the abutment using dental cements, while removable partial denture have been attached to abutment by various types of retainers, that is extracorneal retainers and intracorneal retainers. Extracorneal retainer consists of two fingers of metal, that is retentive clasp and reciprocal clasp. Retentive clasp is located in an undercut area of clinical crown and resist displacement of prosthesis away from underlying hard and soft tissue, that it lies on a buccal or a facial surface of the teeth, while reciprocal clasp lies in a non-undercut area. It will act as a stabilizing element for the prosthesis. Reciprocal clasp always be on opposite side of the retentive clasp. That is, if retentive clasp is on a facial or a buccal surface, then reciprocal arm will be on palatal or a lingual surface of the teeth. Now concentrate on an image. You can see top part, that is rest. Rest usually lies on a occlusal surface for a posterior teeth and on cingulum or incisal surface for the canine and on incisal surface for the incisors. It will give you support to the prosthesis. Next you can see two metal extensions called as retentive clasp and reciprocal clasp, as I already told you. Then comes a proximal plate. It will give you the parallel path of insertion. These all lie on the surface of the tooth. Hence they are called as extracoronal clasps. But intracoronal retainers are different. They are contained entirely within the counter of clinical crowns. For example, complete coverage crowns. In this picture, you can see the arrangement or assembly of intracoronal retainers. It consists of patrix and matrix. The one which is enclosed in abutment is matrix, and one which is enclosed in a removable partial prosthesis is called as a patrix. They will get locked like this. Another method of categorizing removable partial denture is, in this picture you can see, prostheses receive support from the teeth on both the side. Hence they are called as tooth supported removable partial denture. In another picture you can see the prosthesis is receiving support from the ridge as well as teeth. Hence it is called as tooth tissue supported removable partial denture. Also, there are certain terms like interim, transitional, and treatment. An interim removable partial denture is a provisional prosthesis intended to improve aesthetics and function until more definitive or permanent treatment is rendered. Interim removable partial dentures can be used immediately after the extraction until healing occurs. A transitional removable partial denture may be used when loss of additional teeth is inevitable, but immediate extraction is not advised because of some systematic disorder of the patient. As you go on extracting a teeth, you can add artificial teeth to the transitional removable partial denture. It can be worn during healing process and replaced with a definitive prosthesis when extraction sites have healed. A treatment denture may be used as an carrier for treatment material, as a protective covering for surgical site, or as a matrix for soft tissue healing. Interim, transitional, and treatment processes are intended for short term application and should never be used for prolonged treatment, as it may lead to damage or irreparable damage to remaining hard and soft tissue. Other key important terms related to the prosthesis which resist the displacement. Those are retention, support, and stability. These are properties of prosthesis. Retention may be defined as resistance to displacement away from teeth and soft tissue. In removable partial dentures, direct retainers and indirect retainers will provide you retention. Support may be defined as resistance to displacement towards the teeth and soft tissue. Rest and rest seat will give you support. Stability may be defined as resistance to displacement in mediolateral or anterior-posterior direction. In upcoming lectures, I will talk about philosophies of RPD. In that, you will understand the stability property properly. Now, what all will be the treatment option for partial edentulous patient? Either we can give them fixed partial denture or dental implants or removable partial denture. What are the contraindication for fixed partial denture therapy? There is age of the patient. That is, in young patient, they have a large pulp horns. So we avoid fixed partial denture because we can't do the tooth preparation in them. Next is length of edentulous span. There is a rule, that is Ante's law. It tells that when the perisegmental or periodontal membrane area of abutment teeth for RPD must be equal to or greater than the periodontal membrane area of the teeth being replaced. For example, if you are replacing one teeth with the support of two teeth, then it is fine. If you are replacing three teeth with support of two teeth, then it is against the Ante's law. Next, loss of supporting tissue. If you are planning to replace soft tissue of face along with hard tissue of oral cavity, then we should use removable partial denture instead of fixed partial denture, because it could be difficult for the patient to maintain a oral hygiene with a fixed partial denture because he is unable to remove it. So instead of fixed partial denture, we can use removable partial denture so that patient can remove it and maintain the oral hygiene. Rationale for removable partial denture therapy, according to Dr. M. Diwan, he stated that primary purpose of removable partial denture is to preserve that is remaining instead of meticulous replacement of what is lost. Indication for removable partial denture therapy. Long span edentulous area. As I already told you, if it is not following Entei's law, then instead of fixed partial denture, you should go with the removable partial denture, or you can use a dental implants. Next, when there is no abutment tooth posterior to the edentulous space, then you can go with removable partial denture. And next, reduced periodontal support for the remaining teeth, which here you can't give fixed partial denture. Then when there is a need for cross arch stabilization, that is you are replacing on one side and you need support from the opposite side, then you can use a removable partial denture. When there is a excessive bone loss within the residual ridge, physical or emotional problems exhibited by the patient. Next, aesthetics of primary concern. These lines tell that you can replace the soft tissue architecture with RPD more aesthetically than FPD. Why? Because if you are using FPD, there will be dark interdental spaces, but with RPD, you can use denture base with denture teeth, and you can form characterization like diastema or crowding. Next is immediate need to replace extracted teeth. Here you can use RPD more readily than FPD, because when we immediately extract, there will be some amount of ridge resorption as time goes. So with removable partial denture, you can add on resin and maintain the function of the teeth. But with FPD, if there is a resorption under the prosthesis, then there will be a gap formation and leading to the food lodgement. Removable partial denture would be a good option for immediate replacement. After healing, you can go for the definitive replacement, that is fixed partial denture. Next, patient desire. Some patient insist on removable prosthesis because they don't want to fix prosthesis because of two reasons. They don't want the healthy teeth to be trimmed, and they don't. Some people get scared of dental implants, and also some people avoid because of economic reason. Next, unfavorable maxillomandibular relationship. That is when there is a discrepancy in arch size, shape and position of maxillary with mandible. In that time, you can go with RPD instead of fixed partial denture and instead of complete denture. Also, instead of extraction, preserve the teeth. By this, you also preserve the vertical dimension of the patient. Next, coming to classification of partially edentulous arches. Why classification is important? It allows visualization of type of partial edentulous arch being considered. It permits differentiation between tooth supported and tooth tissue supported partial denture. It serves as a guide to the type of design to be used, and it can be universally accepted. Among various classification, Kennedy's classification system is universally accepted. It is given by Dr. Edward Kennedy in 1925. He have classified into four basic classification. So class 1, you can see in a picture here bilateral posterior teeth are missing. Class 2, you can see unilateral posterior teeth are missing. Class 3 shows typical tooth supported partial arch, that is it has tooth on both the side of edentulous space. Class 4, you can see that anterior are missing and it is crossing a midline. So it is class 4. Now what is modification space? In this picture you can see It is typically class 2 Kennedy's classification, but there is one additional space, so it is not called as class 3. Instead, it is called as class 2 mod 1. Any additional spaces other than actual classification is considered as modification space and it is called as mod 1. Next, how to deal with this additional spaces and how to classify this Kennedy's classification, because you only have given 4 basic classification. But when there are additional spaces, what to do? Then comes Applegate's rule for the classification. Given 8 rule to follow and then classify them. Now what first rule tells that when you need to do extraction before classification, then go for the extraction first, then do the classification. Here if you in this picture if you see without extraction, it will be typically class 3 Kennedy's classification, but when you do the extraction it will get changed into class 2 mod 1. Why mod 1? Here you can see one additional space is present. When you do extraction of 1 6 and 1 7, it will get converted into class 2 and the additional space in 2 4 2 5 reason, that is considered as modification 1. 2. If third molar is missing and not to be replaced, it is not considered in the classification. In picture you can see actual missing, so it is considered as the Kennedy's class 3 classification. Rule number 3. If third molar is present and is to be used as abutment, it is considered in the classification. Rule number 4. If second molar is missing and is not to be replaced, it is not considered in the classification. In this picture you can see missing are 2 4, 2 5 and 2 6. But we are not considering 1 7 and 1 8 for the classification because we are not replacing it. So it is typically falls under class 3 Kennedy's classification. Now rule number 5. The most posterior edentulous area always determines the classification. In the picture you can see there are a missing on both the side, but we are considering the edentulous space which is most posterior. That is it called as a class 2 instead of class 3 because we are considering most posterior missing teeth. So there it is called as class 2 Kennedy's classification with modification 1, that is mod 1. Now rule number 6. Edentulous areas other than those determining the classification are referred to as a modification space and are designated by their number. Here you can see there are 3 missing spaces, but we are considering the most posterior edentulous space, that is class, so it will be class 2, and other spaces are considered as the modification. There are missing in 2 places, hence they are called as mod 2. So it is considered as class 2 modification 2. Coming to rule number 7. It tells that the extent of modification is not considered. Only the number of additional edentulous area is considered. See into the picture. You can see there is a 2 picture. First picture shows 1 missing teeth and second picture showing 3 missing teeth. So when you are considering it for the classification, you should consider it as the modification 1. You can't tell 3 missing are there, so I will write 3 mod 3. No, not like that. It doesn't depend upon the number of missing teeth. It only depend upon the space. So it is called as Kennedy's class 1 modification 1. Rule number 8 tells that there can be no modification area in class 4 arches. So any individual area lying posterior to the single bilateral area determine the classification. What it tells that I already told you the rule number 5, that is most posterior edentulous space will determine the classification. So here the most posterior missing is 1/6. Hence it is considered as class 3 modification 1. The anterior teeth which are missing are considered as modification space, and the 1/6 which is missing is considered for the main classification. Next, fundamental design consideration for the RPD. It is very important to select the design because it will connect the hard tissue with soft tissue, that is teeth and residual ridge. As we all know, teeth are connected to surrounding bone via thin periodontal ligament. It will allow displacement of about 0.2 mm, whereas soft tissue allow displacement of about 1 mm or more. As a result, there will be significant difference in a support provided by teeth and a tissue. So it is important to understand this difference when designing removable partial denture. So, what all the design consideration for class 1 removable partial denture? It should have optimum support for distal extension denture bases. It should cover broad area and it should have a snowshoe effect. Snowshoe effect is nothing but you are wearing a boot, that is snow boots, and placing a foot on a snow, and after removing it you will see how much the space that shoes have occupied. Same phenomena should be applied over here, that is you should cover more ridge how much possible, that is you need to take the impression which will record the more space, that is more stress bearing tissue. So inadequate soft tissue coverage can lead to stress concentration, breakdown of underlying bone and decrease in a ridge volume. In this picture you can see this shaded area present the broad coverage. So this much should be your impression so that it will cover maximum area and it will give you maximum retention. Next comes flexible direct retention. When there is a vertical movement of the denture base, the soft tissue will get displaced and it lead to torquing force on a most posterior abutment tooth, leading to its mobility or tilting of the abutment. Hence, in that case, we should use a flexible direct retention so that when there is a application of the force, it will get dislodged from the undercut and allow the prosthesis to get compressed and then coming back to the normal position or its original position. This leads to decreased force application on a abutment. Points to remember. Each direct retainer should be designed to flex or move into an area of greater undercut as forces are applied to the removable partial denture. Clasp design is a key factor in successful removable denture service. Now next, let us know what is fulcrum line. It is an imaginary line connecting the most posterior rest of the denture teeth, acting as the pivot point around which denture base can rotate. Here in second picture you can see it is connecting a premolar and molar teeth. So it is the fulcrum line. Around this the denture will move on application of the force. So to avoid this we give a indirect retainers, that is which will be perpendicular. Here you can see one is given on 1 3 and one more is given in between 2 3 and 2 4. So these are the location of indirect retainer. These will prevent this rotation of the denture. But in class 4, it is not on a most posterior teeth. It will be on most anterior teeth. This here you can see it is passing from the most anterior abutment. So in this, the indirect retainers will be placed in a posterior regions on the molars. You can see in this like this. So it will prevent the rotation of the denture. Now let us understand the concept of indirect retention. In this picture, in first picture you can see when there is application of the force, there is a displacement of the prosthesis away from the tissue. So when we place the indirect retention, there will be no movement of the prosthesis on application of the force. Hence, indirect retention is important in a prosthesis. So, in this picture you can see the overall design concept for the class 1 removable partial denture. Here you can see they have used a direct retention on a premolar and indirect retention on a canine. And one more thing, yes, incisors will be the most perpendicular teeth in perpendicular teeth for the contracting of fulcrum line. But as you also know that incisors are most weak abutment. Hence we are not placing any retention or a retainers on the incisors. Next, coming to class 3 removable partial denture, it is completely tooth supported prosthesis. Hence here you can see we are using a teeth adjacent to the edentulous space for the retention, and here you can't see the more effect of fulcrum line because here it is secured from all three planes. Hence it is most secured prosthesis you can see. Next, for class 2 removable partial denture, they have used a direct, here the fulcrum line will pass from the most posterior molar to the most posterior premolar. So to counteract this fulcrum line, they have given a indirect retention on a premolar, that is say on a 4 4. Like this you can give the typical design for class 1 mod 1 removable partial denture. Next, coming to the class 4 removable partial denture design. Here you can see all anterior 6 teeth will be missing and direct retainer will be placed on a premolar adjacent to the edentulous space, and on a most posterior teeth you can give indirect retention, so the component will be stabilized. This is all about introduction and classification of a removable partial denture. Next, we go for the connector, minor connector, rest and rest seat. I will talk about this in a next video. Thank you so much. So please follow my Instagram account, that is Dr. Dontic, for more updates on a video. Thank you. Removable partial denture design. Here you can see all anterior 6 teeth will be missing and direct retainer